The most important element from the study to be understood is that we weren't looking at a low dose versus a high dose strategy. We were looking at optimizing the dose. The goal remains the same, is to try to get the highest dose tolerated by the patient, but there are different ways to do it. So the standard dose was 160, and 160 would be adjusted, mostly closer to 120 for many patients, so they can continue on trial. Our dose optimization strategy went the other way, would start with a low dose, and every week the intent was to go up on the dose to try to reach the goal. So there's the intent and the goal. The intent is essentially to optimize the dose. The goal is to reach the maximal dose, the 160. The dose optimization strategy is designed to try to reach the maximal dose that we think the patient will tolerate. It may end up being 120 for most patients, but there are actually few patients, well, more than few, about 20%, and we're going to look a little bit more at those numbers, that we do reach 160 and stay 160 through the through their lifetime exposure to regorafenib. So again, I think for community oncologists, it's very important to remember that this was not a low dose versus a high dose. This was a start point with a low dose with a goal to reach 160 if the patient tolerates it, versus starting on 160 from the get-go.
In my personal experience, I've used regorafenib at a lower dose for some time, just because I have noticed the difficulty of patients tolerating standard dosing. Which is why I was so happy to see the ReDOS data, that the efficacy was not compromised with a lower dose. And we've also started to be very proactive with management of toxicity, including dermatology referrals early on, podiatrist for foot care, because that was one of the main issues, that patients were not did not have proper foot care prior to starting the treatment. We know that looser shoes are better than tighter shoes, so those are the types of things that we've incorporated into clinic that I think actually make a difference in terms of tolerability, in my personal experience.
Many of us who treat a lot of colon cancer patients with this drug have been doing that for some time. And that, I think, is one of the main important values of the ReDOS study, is it reaffirmed what in practice oncologists have been doing, which is starting at a lowest dose, 80 milligrams, which is half the starting dose of the drug, and increasing it in a very thoughtful fashion, week by week, and if possible, getting to 160 milligrams, but if not, stopping at least a biologically active dose, which is felt to be in the 80 to 120 milligram dose range. It's much more important to keep the patient on an 80 to 120 milligram dose range at a continuous point, rather than stopping and starting at an intolerable dose level. And it's taken some time for regorafenib usage in that situation to be adopted. But now with the ReDOS study, I think we have affirmation of how to best dose escalate and keep patients there.